Percentage of the population. Different countries have different definitions of what are rare diseases. Most of them tend to use the prevalence rate. Like, for example, in America, it's a disease affecting fewer than 200,000 people at any given time. In Japan, it's 50,000. Rare diseases are about 6,000 to 7,000, with new rare diseases being discovered every year. 72% of these rare diseases are genetic in nature, and 70% affect children, and unfortunately 30% don't live past their 5th birthday. Currently, there's only 5% treatments. 5% of these diseases only have treatment. 95% are still being managed without treatments. That means you have to treat symptomatically. Currently, there are over 300 million people living with rare diseases worldwide. So individually, rare diseases are rare, yes, but when you put everyone together, it will be like almost 6 times the size of Kenya. Rare diseases are now recognized in the Universal Health Coverage document, where 103 member states signed commitment to give priority to rare diseases as well as part of other NCDs. The common challenges with rare diseases is misdiagnosis. The problem is most of the times these rare diseases have symptoms that appear vague and nonspecific and may appear not to be so alarming for physicians. This prolongs their diagnostic odyssey. So you find in developed countries, you'll find it will take about 7 to 10 years for a patient to have a diagnosis of a rare condition. You can imagine in the developing countries, this will take even longer. This means that in their search or quest of getting a diagnosis, they'll have inappropriate treatments and even surgical interventions that they did not need, or even they worsen the condition. This means that either by the time that you get your diagnosis, time has gone so much that the disease has advanced to an advanced stage. That means that you cannot recover from. There's lack of access to treatment and care, and extensive travel to just access services. If you give an example of Kenya, most specialist doctors are found in the urban and mostly Nairobi. So you can imagine that person who's coming from Lamu or Turkana has to just traverse across the country just to come and get treatment or to be able to see a doctor. There is limited or non-existing treatment options, given that 5% only have treatment options or other cures or even medication that can help. But the remaining 95%, even when you do get a diagnosis, there's not so much. You just need to be able to manage this disease as much as you can. There's lack of information and support in the disease progression. If you look at diseases like a case that we have of stiff person syndrome that affects 1 in a million, it means that even then, there's still no information for doctors to know how this disease will progress, what it looks like, the prognosis. There's limited people to be able to even do the research on. There's social cultural factors that are unique to Africa that you'll all, I'm sure, have come across, that people will believe that this is an issue of being bewitched. It's a bad eye or it's a curse. So people end up not seeking treatment and believe that maybe a mganga will be able to help them. When in the actual sense, you need the treatment, you need medication that can be able to at least arrest the condition where it is, or be able to manage it and get a better prognosis. The status of rare diseases in Kenya is that currently we lack a rare disease definition as a country. We do not have a rare disease registry or database. We do not have information on the incidence of these diseases. What types of rare diseases are there? Or where can they be found? Or who can be approached for this information? We do not have newborn screening protocols as a country. Take a look at a condition like sickle cell anemia that is found in sub-Saharan Africa. You have about 6,000 live births, children being born with sickle cell when they can be screened early in life, and probably other interventions can be pursued. There's inadequacy of specialized healthcare providers. We currently do not know of any genetic counselors. I know we now have a pediatric geneticist, but these specialized healthcare providers can be able to even help with the diagnosis of a rare disease. You'll be able to have an informed family planning for your future, for children, if you want to have more children, because of them being genetic. That means the inheritance and getting more children with the same rare disease is high. High medical costs. People have to, out of pocket, you have to go to private hospitals to just be able to see other doctors in the cases where none is available in the public sector. Rare conditions or even genetic condition, most of the times are not covered by insurances. And if you are lucky that they'll be covered, you'll find that they have a lower limit. So you find an insurance will tell you only are capped at 50,000 for this condition. So you can imagine you have to keep going back to your pocket to constantly seek medical care. The stigma and discrimination in society, you're constantly having to tell people that, I have this, then they think you must have done something. Like in my journey with Jobera Syndrome, I remember a neighbor coming to tell me that if you had prayed enough, this would not have happened. And that was a very interesting discussion. And for every person who has a rare condition that we have, the members that we've talked to, that is the one thing that you hear. Either you'll get stigma from even their own family, or even your spouse will leave you because they believe this came from your side of the family, they don't have this in theirs. And this brings a lot of anxiety, stress, and leads to high risk of psychological issues. The mental health of some of our patients is, it doesn't look good because they feel isolated. You're constantly feeling, or even at the beginning, even in your journey, you constantly were told that this is in your head. You're psychosomatic, because these illnesses, sometimes some of these illnesses are invisible. You can't see them. So it is assumed that because we can't see them, then it's possibly in your head. Currently, with COVID, there are several issues that people with rare conditions are facing. Unavailability of medicine due to supply problems, canceled or postponed surgery or treatment interventions, like the person, the picture of the lady, she's called Elizabeth. She has myasthenia gravis. She needed surgery. And when she was going for the surgery with the cover from NHIF, she was asked to pay up to 2 years in advance. And even then, her surgery had to be postponed because her doctor was not readily available. They suspended inpatient treatments such as physiotherapy, occupational therapy, speech therapy. We had to cancel our occupational therapy for our son. And 1 year later, we have yet to come back to where we are. So there was regression. We were almost starting to walk at the time. And because we stopped going to hospital, or even we avoided having therapists coming over, it meant that he kind of regressed. So that means that we're trying to do catch up at the moment to get to where we were last year at the same time. There's hospital and clinic avoidance for obvious reasons. High levels of anxiety and isolation. You're wondering, how will this condition affect you? And of course, the unavailability of doctors for consultations. So that's why we formed Rare Disorders Kenya. We're a patient-led organization, and we create awareness and advocate for people living with rare diseases in the country. Our objectives are to raise awareness about rare diseases in the country, promoting research and data collection. We work with the national government and other stakeholders and provide support network for rare disease members, especially for those who do not have a disease-specific support group. So we always ask our members when they join us, please join the global support groups, because that's where you'll be able to get the daily living solutions on some of your diseases. Sometimes even like for my condition, the conditions that my son has, Jobera Syndrome has a guidelines of what to look for and medical notes for doctors. Then I'm able to go with to see whichever doctor I'm going, I'm like, these are the notes that you can go through and what we need to look at. Sometimes even you'll be told that some of the medication that you shouldn't give as that child. Our achievement so far is that awareness has been growing each year. Last year, we reached 150 people who joined us in person. This year, we will have a virtual event. Please join us on the 27th. There'll be a poster at the end. We have forged new links with international organizations such as International Gosha Alliance that has been able to provide medical drug sponsorships to some of the members with Gosha. We've joined NCDAC, that is NCD Alliance of Kenya, to be able to push for NCDs to be recognized and at least something to be done regarding NCDs. And even then, rare disease still there's a lot of work, there's a lot of exposure that needs to go. We are an affiliate member of Rare Disease International, which is the known body for rare diseases globally, with EuroDis in Europe. This coming year, we'll have a rare disease workshop that will bring different stakeholders, and for the first time, we'll be able to have that conversation on the table of what do we need to do about rare diseases? How can we define rare diseases? And probably just that roadmap to have research in the country to be done regarding rare diseases incidences, as in where do we start and what do we need to do in the coming years. So far, we've been able to collect 49 conditions of rare diseases. I believe there's much, much more. But because we do not have a database, or we have a way of referring or a way of collecting data and knowing how many rare diseases are, these are 49 conditions of people who have reached out to us, or we have seen them on the news and reached out to them. So what can you do as a doctor, you could ask? So there's the attitude of common things are common. So rare diseases are put on the back burner and they're no longer even considered when you're looking for a diagnosis. So we say, dare to think rare unless proven otherwise. The clinical responsibility to care still remains. And you can be able to recognize the pattern of someone having a rare disease if you are able to expose yourself to how rare diseases are. And later on, I will give resources of where you can get to and to be able to look for and consider, could this be a rare disease for your patients? The importance of early diagnosis and management cannot be overemphasized. For physicians, break the loop and consult with other experts. Multidisciplinary approach to patients is important because sometimes patients are unable to communicate the medical symptoms. For example, like when I would have when I would be meeting different specialists, at some point we were having like 6 specialists for my son. We are looking at the neuro, we are looking at the gastro, we're looking at the nephrologist, we're looking at the ENT, we are looking at the chest doctor. And I have to do the project management of who do we see, what is going on. So when something happens, I have to consider which doctor do I need to call. While this has changed over time, and we have a doctor like a neurodevelopmental doctor who can be able to manage this conversation. So they say, okay, I need to have a discussion with the chest doctor regarding this. So that has made life easier for us. But I know that is lacking for most people. So you constantly have people having that ping pong effect. You go to this doctor, you go to this doctor, and then you have to go back to this doctor. So if we could have that discussion that approach people with rare diseases, or probably even with other chronic conditions, and have those discussions and be able to better manage that conversation among yourself and have better care for your patient. Show compassion and empathy. See the person within the disease and appreciate that what it means for them to have a rare disease. It can get so complicated. Seek continuous education, and thank you for joining this and learning more about rare diseases. Later on, I will share resources about medics for rare diseases. They have formed an online platform that teaches you about rare diseases, how to diagnose, and a lot more. Listen to your patient and be open. This is one area that you'll hear people with rare diseases constantly bringing it up. If you listen to the rare or even to those patients, you'll be able to get a better patient history. Also, be open to the fact that with rare diseases or people who already have a diagnosis, they become experts in their condition. This is because they've had time. I constantly research about Jobera syndrome almost daily. Whenever there's a new research that has been released, I'll be the first to know before my doctors know. So the traditional hierarchy of doctor up, a patient below does not work when you have rare disease patients, because they're empowered. They've had the time to research on this one disease. So when you come to the table, be open to have those conversations, and both of you chart a course on how to manage their conditions. Mental health support. You cannot manage rare diseases in isolation of the mental health. Most of the times, with the lived experience of not being believed and having symptoms explained away as a mental health problem, you find that they already have issues with even trusting you. Will you believe them? They've been battered. And then the whole thing, you have to keep retelling your story from one doctor to another. There's the challenges of living with a rare disease can precipitate mental illness. Sorry. And finally, a rare disease in itself can contribute to neuropsychiatric problems. Take an example of Huntington's disease. So you cannot be able to you can't just look at the patient clinically. Think about even the mental health of this patient, because it's part and parcel of their holistic care. Support and be supported by patient advocacy groups. Refer patients to support groups for the psychosocial support. They'll be able to get solutions for the daily challenges that they meet. They'll be able to accurately get educational materials that they can even come back and give it to you. And this supports you also. They can also be pointed towards research opportunities. For example, for my son, we were able to put them in a research program for University of Washington, hindbrain malformation research. And that is where they get a lot of information about the current status of Jobera syndrome. And that, like, currently they have about 30 causative genes for this disease. So regarding resources, so where can you start if you're interested about rare diseases? Again, Medics for Rare Diseases, they have an online platform that gives you information. They call it the Rare Disease 101 for Medics. There's platforms like OMIM, Mendelian, Find Zebra, where you can put symptoms in case you have that patient that doesn't fit. Phenomizer, there's a medical database such as Orphanet, Node, and GARD that has information about rare diseases, especially when you already have a diagnosis that you can refer to. At this point, I would like to ask Christine to provide a case study for ring 18 chromosome. Christine?
Thank you, Roselyn. Ring 18 chromosome, that's a case study for my second-born child. And in a nutshell, it's how the way the chromosomes look like an 11, but on the 18th chromosome, one has fused into a ring. So it looks like a 10. So that's the layman's description of ring 18 chromosome. The common symptoms include weak muscle tone, congenital abnormalities, heart issues. You have fit structural issues, you have endocrine issues, delayed development, and intellectual disability for some. It's also a spectrum because it also depends on which arms have been fused and to what extent. So that's the big and nutshell of what do you call it? The book side part of ring 18 chromosome. I'll explain to you the physical part where I have lived with my daughter. Second slide, Roselyn, please. So this is Kayla. She was born very underweight. She was 1960 grams, yet she was born at term. She had delayed milestones, walking, sitting, eating. She had bad reflux. She had, what else did she have? Now she has kidney issues. Currently we are battling diabetes type 2. We are battling hypertension. We are battling Hashimoto's. So all these are just part of the spectrum, in quotes, of ring 18 chromosome. Not all children have all that I've spoken about, but most of it have, because we find like how we started testing for hypothyroidism was I went online and asked the group that is for chromosome 18, and they said most of our children get thyroid issues. So I came back and asked the doctors that it is best we just start testing for thyroid issues. If you can look at the photo on the bike and the one on the left where her name is, you can tell she's really considerably added a lot of weight. So you find that that is thyroid issues, and now the thyroid is autoimmune, so there's nothing much you can do about it but treatment. And I don't know if Roselyn mentioned this, but what we advise our members is to go join the global support group, where you'll get all the information from patients, parents, caregivers of those with the same condition. There's some knickknacks that they can give you that your local doctor will never know. For example, how I should have started testing for thyroid before it became too late. So by the time we were getting to Hashimoto's, we already managed it for a while and it hadn't gotten serious. So that's what we urge members to do. Once you get a condition for your child, go online, search for the global group. If they have I'm lucky mine has a registry and research center, of which I'm the African ambassador. I get to get first-hand information on how to deal with ring 18. I have a medical folder full of ring 18 that I walk around, take to my daughter's doctors every single time we go, so that at least we are not revisiting a conversation every time. If they don't know about ring 18, all I have to do is hand them the folder, they peruse through it, and they get to have an idea of what they're dealing with. Also, she's 9 years old. She has speech delay. She's really tried though, but she has speech delay. She has delayed milestones in that she can't jump that high. She's just learning how to jump. She just got potty trained thanks to COVID, because she's at home. And basically just trying to thrive. But the advantage of it is she's a very happy girl. So there's no pity party here. She's a very happy girl who enjoys laughing and all. So with each of all these conditions, you'll still find at the end of the day, the child is still a child. Thank you, Roselyn.
Thank you, Christine.
Thank you, Christine. That was a very, very touching story. We pray that God gives you more strength in whatever the endeavor is. And we are very grateful for you to share your story. Roselyn, I think you also have a case study.
Yes. I was checking the time if I will be allowed to share mine. So my son has Jobera Syndrome, and it's a rare genetic brain malformation with the MTS sign. This is the molar tooth sign that is the acceptable diagnosis for Jobera Syndrome. Others have looked to gene testing, but the molar tooth sign currently is the acceptable diagnosis for Jobera Syndrome. Currently, there are 30 causative genes, and it's the part of group of diseases called ciliopathies that's growing. Jobera is broad spectrum. So you find that for every child, even in the same family, you'll find one is severely affected, the other one might not be so much affected. The prevalence rate at the moment is 1 to 80 or 100,000. Common symptoms are weak muscle tone, there's abnormal breathing, tongue and eye movements, there's delayed development, and cognitive abilities are variable for each. In fact, we had a case about 2 years back in the global group where a 52-year-old was diagnosed with Jobera syndrome. He had a family, he was working, and he just started having headaches, and they did a brain scan only to find that he has JS. There are distinctive features, facial features for Jobera syndrome, where you have bulging of the head, drooping eyelids for others, downturned mouth, among others. There are other abnormalities also present, or other diseases also that go with it. Skeletal, liver, kidney, eye, heart, and hormonal involvement. Currently, there's no cure and treatment is symptomatic. Prognosis is favorable, especially for the mild forms. So let's meet my Morgan. So we got a wrong diagnosis at our 8th month pregnancy scan, and we were told that it's a Dandy-Walker variant. When he was born, we had challenges with severe jaundice due to ABO compatibility, and we had to do a blood exchange. And later he developed neck, necrotizing enterocolitis, but there was no surgical intervention. So at 21 days, we went home, but we were not out of the woods. For the past 6 months, we were constantly in hospital. Every week, we were seeing the doctors for one thing or the other. One of the issues that was present at the time was that there was failure to thrive, which was later resolved with feeding issues. We had issues with gastro that was seen from even from the 2 months. He had distended stomach, because we came to later realize that he had slow gastric emptying. At 4 months, a doctor asked for a brain MRI to be done. And that's when we got the correct diagnosis of Jobera syndrome. I must note though, for us, this was a huge, we were in luck, I would say, because even abroad, you'll find that children have gone through numerous MRIs and the radiologist did not catch it until one doctor or someone was able to finally see that this is JS. For us, we consider ourselves very lucky that we got this diagnosis early and we know what to look for. So consequent months, or rather subsequent months, we had sleep apneas, but because we do not currently have sleep studies for children, we had to manage at best the way we could think, because we weren't sure, is he getting sleep apneas or not? So if you have an oximeter, his oxygen levels will go down to 89, then come back up, 89. And children with Jobera also have what sometimes is called panting. They can pant for hours. Forgive the illustration, like a dog, like the way you pant for long, and it could go on for so long. That is where we say abnormal breathing patterns. For Morgan, it wasn't severe. When he's unwell to this day, you'll notice the oxygen levels keep dropping. They'll go down to 89, stay a bit, and then come back up. And our doctors at the time said, this is normal for him, but nevertheless, they have to be managed. For JS, the sleep apneas most students seem to outgrow them at 6 months. We had gastro reflux issues, which was so severe at some point we considered funduplication, that is the wrapping of the stomach, possibly a peg to be put in. We had mild blood pressure issues because he has cysts in one of his kidneys. He has multicystic dysplastics. The left kidney has cysts and it's no longer functional. However, the right kidney has taken up most of the function, but we try as much as possible to maintain that kidney. So it means that some medication he can't be given. There was sensitive gastro issues, as I'd said earlier. Gross motor skills are greatly affected. So now he's 4 years, and this is him. He can sit, but if he falls down, he cannot bring himself to sit. However, you'll find that his emotional intelligence is quite ahead. Recently, he's learned how to get our attention by pretending to be choking, which is actually, for him, it is a reality. So even when you give him water, he's still being bottle fed with liquids because he can't drink by a cup. And even then you hear a bit of slight choking, not really choking, what's the word for it? Where you're not really choking, like gagging, that's the word. So we have to constantly ensure that his food is also pureed to some extent, but it's all a work in progress considering where we've come from. Processing speed is weakest in JS. You find that it takes them a while to respond, like even stimuli, you call him and it takes him a few seconds to realize, huh? But he's a very happy child. That's the good thing with Morgan. It makes it easier. The role of international support groups cannot be, again, underplayed here. For us, it made a huge difference. Sometimes I'm like, is this normal? I go back to my groups and say, is this normal? Then they'll be like, yes, my child does this and we do this. Or please ask your doctor about this. So they're not replacing the importance of your doctor. Sometimes it's to just consider, could there be something else? Do we need to look at this? Current situation with Morgan is that we constantly have to manage his kidney functions, ongoing therapies. He's currently nonverbal, but we find our way to communicate. He has mild ataxia. However, the prognosis looks good for him. A lot of medical emergencies dissipated somewhere around just before COVID hit. So now we are looking into homeschooling. He has a teacher who comes and he loves to learn new things. So it's not all doom and gloom, as Christine said. Thank you, Amina. And that's what we have for you. We will welcome any questions. Oh, and we invite you to our free webinar on the 27th from 10 to 12 p.m. Yeah. Amina, back to you.
Thank you very much. I cannot say how much you've impacted me today, as both as a mother and as a doctor. You say he's emotionally intelligent. The thing is, I actually believe you are the one who also has a big role in him finding his way of being able to express himself and being able to share his emotions. And I cannot be more proud of you. And I don't think, given the situation, anybody would have handled it the way you have, both you and Tristan. And thank you very much for your initiative to starting the foundation and your initiative to also teach us more about this. And definitely we will join in the session on Saturday, 27th of February, which would be the World Rare Disease Day. So I'll take up questions and answers from the team. And okay, there's somebody who is making a comment here. Thank you for your efforts. Do we now have a countrywide awareness and management plan? How would you like medical associations to come in and develop management outline? Dr. Wambani Sidika, thank you very much. You have read my mind. So Roselyn and Christine, kindly answer. How would you want us as a medical association and a medical society to play a role in this?
Wow. We cannot do this without your partnership. We cannot do this. This is something new for us also as we learn, as we're going. One of the things that we need, like medical patrons sometimes, to have these conversations, to fellow doctors. We are, with the upcoming medical workshop, we'll be looking to the medical associations to come on board and have that discussion, because we'll have key players even in the government, the Ministry of Health, to have this discussion and have a medical plan, a definition, what do we do next? So we really would love if you can join us on that time. At that time, we will we'll reach out. Those are some of the ways. And of course, the little things that you do as a doctor. If you do have someone with a rare disease, send them our way. They have a community that they can, meet. And also, as when we do get around to forming the database, you can refer information so that we can be able to start picking data of rare diseases. Christine?
Yes, sorry about that, I was muted. I think you said most of it, but as Roselyn has emphasized, we need doctors to listen to patients. Listen to us when we come and tell you, I have a gut feeling my child is not okay. Or listen to us when we say, I think we need to do further tests because of ABCD. So that at least, let me quote her, she said, doctor on top, patient at the bottom. We need to be on a round table to discuss, because we can only manage and or treat these rare diseases if we come together as a group. Thank you.
Thank you. Let me pick another question. Most of it is comments, people saying thank you. There's a question here on spinocerebellar ataxia in the group of rare diseases. Do we have specialists? Okay, we were told there's no specialists specifically for rare diseases. However, is there a way you can show us the 49 registered? Is it somewhere where you can share?
Yes, we do have them.
Kindly do, so that we can be aware.
Let me find the file shortly. Let me stop sharing and then I will share this.
Yeah, thank you.
Thursday?
Yes?
I have mine ready. I don't know if I can share.
Yeah, sure.
Yeah, please do share.
So I don't know if you can read this. I've kind of reduced the size so that everything can fit onto one page. Dr. Amina, is that okay?
Yeah, that's okay. I'm actually surprised sickle cell anemia is part of the, wow. I know it's worldwide, but locally it's, yeah. And I love the point that you guys said, we need to do enough newborn screening, especially for thyroid, for blood-related diseases like sickle cell anemia. There are some areas in the country we already know that they have a lot of that. So we should ideally be proactive in seeking them out as opposed to waiting for people to develop the symptoms. And if anybody from Ministry of Health is listening to this, I'm sure probably there's one person or two, or even a person of influence, we can pick up these conversations when making this, in converting this into a policy as opposed to just something where we are going with the flow. Surprising, I don't know, it's Casabat-Merit syndrome in here. Because last week we had a case like that in KNH. Basically the child, not last week, I think last month, we had a child who presented with proptosis, was sent to the ophthalmology department only for it to be a neurological tumor. And it was so aggressive. I don't think even there was time to intervene, because the proptosis was like one day you're seeing it like this, and then the next day it's actually out. And that's the reason why they were sent to an ophthalmologist. And when we did the tissue analysis, it was actually a hemangioma. It was associated with thrombocytopenia, low platelets. So unfortunately, the baby did not make it. And I think these are the rare diseases that don't even reach anybody's radar, because I mean they don't even make it. It's very aggressive and it needs timely. But the most interesting part is when I was talking to Dr. Walong about the biopsy, he told me, I see this a lot. And then and then he says, but then this is KNH, so we normally see a lot of weird things, because I was trying to convince him it's rare. So I guess that falls into the category. Maybe we need to put that in the list. Yeah. As a caregiver to a patient with myasthenia gravis, I appreciate all the caregivers of patients with rare diseases. Thank you very much. Sorry, I said Kasabak-Merit syndrome. Maybe I will type it somewhere. It's a bit hard, but yeah. Most of the things are more of comments. Thank you very much. People mentioning about government support. Another thing that probably I would advocate for is, if you're a registered caregiver of a person with rare disease, I believe you should be exempted from paying taxes, like somebody who I'll be vocal about that because I know how expensive it is. So I think that should be taken into consideration, people who are taking care of people with rare diseases. How about the role of physiotherapy, and how do you find the support in the country in terms of occupational therapy, physiotherapy? Do you get enough? Is it hard for you to, speech therapy, all of those things?
Okay. Roselyn, I can go?
Yes, please go ahead.
Yes. So for me, my daughter has had occupational physiotherapy, and she's currently going through speech therapy. And as much as it's easily available, it is a dent in the pocket, because it is therapy that is not limited to time, and minimum is 2 to 3 times a week. So you find that as much as starting speech therapy, because that's what now my daughter is on, I have it's for forever till she gains her speech, or till the speech therapist says, I think we've improved, let's do this and that. So it, as much as it may not be so much, but still a lot, it's just the fact that it's unlimited makes it very expensive.
Yeah,
add?
Yes. Kindly add.
So in our case, we need speech therapy, we need occupational therapy and physiotherapy. So sometimes you find that as much as some of the physiotherapists and occupational therapists are widely available, the quality is wanting. We have cases where you find that they do more harm than good, dislocations of like shoulders, or doing certain therapy techniques that actually cause more harm. So it is one thing that for me personally, I would like to see more being done. And we've been in talks with like people who we think they can push for quality physio and occupational therapy. We would love to have speech therapy, but currently it's such a big dent in the pocket that it is something that you start learning to do. You either have to go see one person one month or 2 months, and then you go try it at home. So speech therapists are not that easy to find. And if you do get someone, I remember one person was charging 10,000 per session, and you can imagine I need 3 of them in a week. It wouldn't make sense.
I'm glad we're having this discussion, because I am here with Christine. I'm actually going to take her to our occupational therapy and physiotherapy in KNH. She told me she has not been in KNH for a very long time. It's good for me to open her eyes and see what's available in the public sector as well, because most of the time, I remember the first time I worked in Kenyatta for I think almost 4 years right now. And the first time I walked into our physiotherapy department, I was in shock, because I actually paid for my daughter to have a speech therapy somewhere in Upper Hill. and I removed like almost 4,000, which was really not necessary, because we have the same people who are more trained in KNH, and I was not aware. So these sessions here are to create awareness for us to know what's available, both in public sector, private sector, and all sectors, so that we can look at how we can be able to go through these sessions without really affecting our financial pockets. Yeah. So let me look for another question. As I said earlier, most of them are really comments. Thank you, the Lupus Warrior. We are with you as well, and hopefully we're going to have a session on lupus as well, hopefully this year. So I don't know. Do you have any? I have muted. I have actually allowed some people to speak. The ones who raised up their hand. Lillian. I don't know if you can unmute yourself. You, Grace, and Martin. I don't know if you can unmute yourself to be able to ask questions. Lillian, Grace, Martin, any of you. I'm unmuting more people just in case whoever is able to do it. Maybe another thing to bring awareness of, I read weird things and listen to weird things. There's this documentary on Netflix called Diagnosis. I don't know if you're aware about it. If it focuses on rare things. There's a journalist in New York Times who's partnered with New York Times, and if you have those things that nobody can figure out, they post it, and people, yeah, I found it very, very very informative, because it could be as something little as your diet that can have an impact, and it can actually help somebody in doing that. But what I can ask you before anybody unmutes themselves, sorry, Emmanuel, is have you had any genetic testings?
Yes.
Personally, for me, maybe I should have mentioned, both my kids have different rare conditions. And when the second born was confirmed to have delayed milestones, we opted to do karyotyping for both of them. So, but then that was still very expensive, because that was in 2013. But I know we need to do more tests to find exactly which gene has been affected, or what we need to do further. Or like, for example, for my second born, the one who has ring 18, it would be best if we figured out exactly which arms how much of the arms have been deleted, so that we can get to know exactly what you're looking at. So it's right now it's a bit not so costly. It's still costly, but not as costly as before. Yeah.
For us, for my son, we joined the research, University of Washington hindbrain malformation research, and they were doing the testing at that time. And unfortunately, it was inconclusive, and they keep saying, just hold, as more what do they call, causative genes are being discovered, they will run the panel again. So for us, that is as much as we've done. But there's something that I forgot to mention, the importance of why you need to have a genetic testing done. Because especially for Jobera, with the 30 genes, some particular genes will show a certain, the prognosis or the progression of the disease will be in a certain way. You'll have kidney involvement, or you'll have heart involvement. So if you are able to know what gene caused what, then you're ready to preempt. You start checking already those organs for any issues that might crop up, so that you're not caught unaware. Amina?
Thank you, Rebecca. Sorry, Roselyn. I have a very invasive question to ask. How about family planning? Considering 2 babies for you, Christine, have rare diseases, how is that affecting you? How have you dealt with that? Have the caregivers offered you such solutions of family planning and what have you? How, basically take us through that, if you don't mind.
It's okay. Personally, there was no genetic counseling then in 2013 in Kenya. So even when the karyotyping results from my daughter came back showing 18 chromosome, the comment below that, they have the comment at the bottom of the test results, it was genetic counseling is advised, but I didn't know where to go. And I thought of my firstborn has a rare disease, my secondborn has a different rare disease. What's the probability, what are the odds that the thirdborn will not have? So I couldn't risk it. As painful as it was, I had my tubes tied. So at least I had to ensure that since the odds were greatly against me, let me not. I was open to adoption. So it wasn't like I was closing that chapter. I just didn't want, because no one could assure me that all will be well. So I took drastic measures because there was no help then for me. Yeah.
For me, we would love to get another child, but this is a big stop and wait kind of moment for us. So whether we are going to have more children, the risk is too high, considering that we did lose a child in between at 5 months with severe malformations. It definitely is something that we can't take lightly. And at this point, I need to say something that I hope it will be taken well. So as a doctor, I've met doctors who tell me, just get another one. But you see, it's not as easy as that. If I get another one, then they have JS, and this time it's even worse. There's no pause button. There's no going back. We will have to deal with this. So it's not a light discussion. And I see sometimes doctors are like, just get another one. It will not be the same. 25% chance is still a chance. And you will have to deal with that for the rest of that child's life and, taking care of that child. So the jury is still out as whether we'll have our own child or we will adopt.
Thank you very much for opening about that. I know it's not an easy journey. Some things are easier said than done. Any of the speakers who I have given the rights to speak, I don't know, would you want to ask a question? Emmanuel, I'm sorry I interrupted that time. You can unmute and speak.
Yes, thank you so much. I want to say that the question I wanted to ask was already answered by the previous speaker before this lady came with this presentation. However, I wanted to really say most of the genetically mutated, let me say, diseases that we get are always very, very hard for us to cope up with. I personally had an experience whereby in a family where we had a sickle cell, it is really very hard for patients or couples to cope up with situations that come their ways. And I would say most of these teachings that we have could really be helpful when it is rolled down to the community so that we really see how to help our people, because people are dying with pain and lack of knowledge of how to deal with these situations.
Thank you, Emmanuel. I know I said we take sickle cell as not common, but clearly we don't consider it common because we don't even do screening before after delivery. We wait for the symptoms to occur before actually doing the appropriate investigations. And I believe a lot of people are listening, and a lot of people will take up and follow up with whatever you've mentioned.
Yes. I think my network jammed.
It's okay, Manuel. We had
My
your
network has
comments.
jammed a little, sorry.
Yeah. Thank you. Have a good
Okay,
day.
please. Thank you so much.
Yeah.
Thank you. Good day too.
Anybody else who has a question? I have given a lot of people rights. Lillian, Martin, Richard, you may speak. Some comments here. Somebody is making a comment regarding there are lots more rare diseases out there and we need to update the registry. I know of a single parent raising a child with autism spectrum disorder and another with SLE. And unfortunately, I don't think autism is classified as a rare disease. However, I believe Christine and Roselyn have mentioned that they are there and they're willing to update the registry together in guidance with MOH. And there'll be guidelines on what's considered rare, what's not considered rare. And I think this is the forum where these discussions probably will be taken up further in terms of speaking what classifies as rare and not rare in Kenya. So without much further ado, because I don't have any other questions, maybe I invite Christine and Roselyn to give their end remarks. And yeah, Christine.
Thank you, Dr. Amina. I'm seeing you had an average of 800 participants. And I'm glad because at least you know the word is out, that there are rare diseases. There is an organization that supports parents, people living with rare diseases, and that there is hope. You don't have to walk the journey alone. So I'm hoping that as we have preached the gospel to them, they will go forth and seek and share the gospel with others. Thank you.
Thank you. Roselyn?
Okay, Christina said most of it. And for me, again, is to thank you for taking this time. Please do more research. Go to Medics for Rare Diseases and get more information and arm yourself with the information, because if you start with thinking a bit differently and just looking at your patients and taking care of differently at your patients, then we've gone a long way at addressing the issues that come with rare diseases. Remember that just because there's no treatment does not mean that there should be no management of these diseases. Thank you, Amina.
Thank you. Thank you again. Thank you for listening. Thank you for questions and answers. And I hope we shall join again tomorrow, 7 p.m. The topic will be on sexual gender-based violence. It's a continuation of last week's series. So join in. I will see you tomorrow. Thank you again. And thank you, Roselyn and Christine. We appreciate you. I love you. Take care. Bye.
Bye.